Hello friends, today we will discuss a case of rectosigmoid CA where laparoscopic anterior resection was done. 39-year-old female coming with history of bleeding PR and on colonoscopy showing a polypoidal growth at rectosigmoid junction, biopsy of which showed infiltrating moderately differentiated adenocarcinoma. CECT showed the same with the query serosal breach and the PET-CT showed a wall thickening at rectosigmoid junction with few pericolic lymph nodes. Standard ports were placed and thorough inspection of the abdominal cavity was done to look for any distant metastasis. Liver looked alright. Peritoneum was unremarkable. There was minimal serosanguinous fluid in the peritoneal cavity. Sigmoid colon was inspected, pulled up to look for the lesion. So this was the site of lesion right in front of the sacral promontory. Uterus was alright. Ovary showed a small simple cyst on the left side. Sigmoid was lifted up to make the vessel stented. The peritoneum was incised at the level of promontory and it was cored on either side towards the pelvis and towards the colon. So it is important to use the energy source wisely at this point to keep the field bloodless, because any blood in this field can obscure the plane and make it difficult to dissect. The fatty tissue was dissected all around the inferior mesenteric artery and the vein. Few lymph nodes were noted at the root of IMA. Hence, the dissection was slightly progressed towards the proximal side. To obtain as many lymph nodes as possible. As you can see, some of the lymph nodes are very well visible. There was little bit of bleed from one of the small branches, which was controlled. Some more dissection was carried out to exactly delineate the major vessels. Inferior mesenteric vessels were clipped with the hemalock and divided with harmonic. After the division, pedicle and the mesentery were dissected up. Now the surgery continued towards the lateral side. The lateral attachments were dissected off and cut. Dissection continued towards the splenic flexure. So splenic flexure was mobilized laterally as much as possible. So the mobilization was done laterally as much as possible. and dissected off the splenic capsule. The mesentery was dissected off the psoas. So the sigmoid is dissected both medially and laterally till the level of transection. So dissecting sigmoid mesentery of the ureter is one of the important steps. To make sure that the ureter is not in the line of dissection, and the now dissection proceeds towards the pelvic cavity. As it is an anterior resection, mobilization of the upper rectum is good enough for the required margin. The peritoneum is cut laterally and anteriorly till the level of transection. Laterally, the peritoneum is opened on the left side, taking care not to injure the ureter, left ureter. Since it was a bulky uterus, so it was coming on the way of dissection, especially the anterior. So a stay was taken to lift the uterus up. So you should be able to appreciate the course of left ureter during this dissection. mobilized, rectosigmoid is mobilized on the posterior side. Lateral dissection continued on the left side, pushing away the left ureter. So the upper rectum dissected all around, both on the right, left, and on the posterior and anterior side. So once the mobilization is done, the margin is calculated. Once the sufficient margin is obtained, the mesorectum is dissected circumferentially to prepare the rectum for transection. So now the rectum is ready for transection. A purple GI stapler was placed and the distal transection was done. Small phenestrine incision was given and the specimen was brought out. Proximal mesenteric ligation done. And the proximal transection was done. First in taken. And the circular stapler anvil was placed proximally. Trusting suture tied. Make sure that no fat comes at the site of anastomosis. It has to be dissected out, and a clear bowel must be prepared for anastomosis. So bowel was reintroduced into the abdomen Pneumo was recreated. Stapler was introduced parectally. Docking was done. Stapler tightened. And it was fired. Leak test was done by infusing some saline into the pelvic cavity and pushing air into the rectum. So there were no bubbles at the site of anastomosis. After making sure of this, an ADK drain was placed in the pelvic cavity. The port sites were closed. This was the final specimen. Final histopathology was a moderately differentiated adenocarcinoma PT2N0 with no LVI or PNI. Margins were negative. Thank you very much for watching.